Hi, good morning. Again, my name is Catherine Pérez. I'm a third year doctoral student at the USC School of Gerontology. And along with my co author, Jennifer Alshire, we're here to talk about the predictors of mortality among those aged 60 plus in the Commonwealth of Puerto Rico. To begin, Puerto Rico is a Caribbean island located southeast of Florida. It's this tiny little red dot you see up there. Which is superimposed on the front. So Puerto Rico is a U.S. territory operating as a Commonwealth since 1952, with its residents having U.S. citizenship since 1917. Because of their U.S. citizenship, Puerto Ricans can move freely from the island to the U.S. and back, which distinguishes itself from other Latin American countries who do not have this free-flowing migration to the U.S. This status also means that Puerto Rico is affected by U.S. federal laws and policies as it affects the other 50 states. As of 2010, they have a population size of 3.7 million, which is about 4 times larger than the population size of San Francisco, to give some context. And they have a life expectancy of about 76 years, which is 2 years lower than that of the US. To me, Puerto Rico has a very interesting demographic history, which, thanks to the published work of Alberto Poloni and Mary McInerney, we have a way to contextualize the Puerto Rican aging experience among the older adults, which we study today. And that gives us insight to some of the patterns that we may expect in their mortality. So, in Puerto Rico, the mortality transition was stalled by a decade despite initial U.S. health interventions, and this is because there were no infrastructural improvements. So life expectancy did not really begin to rise until after 1950 with what I would like to call the Puerto Rico Industrial Revolution, when it changed from a sugar-based economy to an industry-driven economy, which led to its impressive economic growth and the significant raising of domestic living standards. Thus, older adults who achieved their 60th birthdays between 1980 and 2025 have benefited from these large improvements across the island and large improvements in survival. Another interesting characteristic to consider is that Puerto Rico has had lots of outmigration from the island to the mainland U.S., mainly from lower socioeconomic males who are looking for work. Thus, males who stayed on the island may not represent the original cohort of individuals that include these immigrants. And recent evidence suggests that Puerto Ricans who have migrated to the mainland have worse health than those who stayed on the island. Despite Puerto Rico's impressive economic growth and the significant raising of domestic living standards, the GNI per capita shows a different story. For those unfamiliar, the GNI per capita is the dollar value of a country's final income in a year divided by its total population. So this reflects the average income of a country's citizens. And various sources point that high-income economies are those with the GNI per capita of $12,000 or more. Puerto Rico passed this cutoff as a high-income country in 2003, whereas the U.S. passed this cutoff in 1980. So despite Puerto Rico's similar high-income classification as the United States, this is more of a recent trend that one must consider in looking at today's elderly Puerto Rican population, having been part of a society that has been primarily considered low income for most of the lives of the elderly Puerto Ricans today. In addition, Puerto Rico is considered to be a small island developing state despite its high-income country status. This means that the island faces sustainability challenge characterized by limited social and economic resources, faces environmental vulnerabilities, has excessive dependence on international trade, and growth and development are stagnant due to the island's small size. And these characteristics are what you will find commonly in low-income countries in Latin America and in the Caribbean. So, kind of putting all of this together, we can try to contextualize the Puerto Rican aging experience since mortality at older ages is the end result of the aging process, and this process is greatly affected by the circumstances in which people age. Particularly, I am interested in how these processes affect mortality by gender. So I have this visualization showing how a country's context affects the experiences by gender that are then moderated, mediated by these various characteristics that influence mortality at older ages. So for the purposes of today's presentation, I want to answer the questions of whether the predictors that we commonly understand in mortality in high-income countries, such as the US, are also seen in Puerto Rico. In addition, I also want to see how these mortality patterns vary by gender. So to answer these questions, I'm using data from the Puerto Rican Elderly Health Conditions Project, also known as PREHCO. It is a two-way panel study of the island population for older adults age 60 and older. The initial interview took place in 2002, with follow-up done 4 years later in 2006. Notably, this data set has an oversampling of African descendants and individuals aged 80 and older in all interviews and conducted in Spanish. And another important side note to add is that PREHCO is the only island-based data survey that exists for the study of this island, hence why we're kind of looking at this picture of a decade ago. So the sample for this study, it first initially began with 4,291 interviews from the 2002 initial interview. Over the 4-year period, we lost 400 at follow-up, so I don't know what happened to these 400 people. We don't know if they lived, they died, they just disappeared. So at the end of the 4-year period, we have 3,243 Puerto Ricans that survived and 648 that died at the end of this 4-year window. So I used Cox proportional hazard models. This was the best fitting model that I chose based on AIC and BIC statistics. The exposure time is time of life till death. And I'm going to look at a series of predictors that include sociodemographic characteristics, disability, chronic conditions, health behaviors, and poor self-rated health. And all analyses are weighted to account for PREHCO's complex survey design. So to look at some of the basic demographics, you'll see that even though there are these linear gradients in age and education across the categories, but when you look at the differences by gender, they're very similar, actually. There was no statistical significance for any of these categories by gender. As you can see, there's not much variation.
Among the 85 to 89-year-olds, there are more males than females? Is that
yes.
Or is that something to do with oversampling?
These are weighted, so if the weights account for that oversample, but that male the male increase in that age group was not statistically significant for female by gender. I'm sorry. So it looks like more, but it's not statistically significant.
Is migration selective of female or male?
Well, earlier in the course of the history, like when the first big out-migration flows from the island to the mainland, it was selective for males, poor males that went to the mainland to look for work.
So that would go in the opposite direction.
Yeah.
When you look at the health characteristics, the adage that we usually understand in the U.S. is that women live longer than men, but do not necessarily enjoy better health. In Puerto Rico, you see that women have a higher prevalence of disability and hypertension, but they look the same as men across the other diseases and self-rated health. And as you pointed out, Ron, earlier, this could be a selection effect of those Puerto Ricans who survived to age 60 and beyond, for those that stayed on the island. And, as you saw with the demographic characteristics, the distributions among men and women are still very similar. I noticed that my next slide got cut off, so I just want to mention that rates of obesity are similar among men and women in the PREHCO sample. And in terms of smoking, 11% of males are current smokers, whereas 4% of females are current smokers, and 15% of females were former smokers, whereas men represented 40% of former smokers. So men have higher smoking patterns in this sample. So here I plotted survival curves, and I did them for the total population and by gender. You can see clearly that there's a female survival advantage. Men were more likely to die over the 4-year period. Here I present the results of the Cox proportional hazard models. What you see presented are the hazard ratios for experiencing the event of death. I modeled 6 separate regression models to first examine how gender differences look like in survival, controlling for a series of covariates. So for M1, that's the first model that I ran with just basic age. And you can see that there's a clear female survival advantage when you just control for age. When you add SES indicators of education insurance status, the hazard ratio reduces, but the female survival advantage is still present. We introduce measures of disability, which is basically whether a respondent reported any ADL or any IADL limitation. It seems like it had a more of a suppression effect. It didn't reduce the advantage, but still females still have a survival advantage in this sample. However, once you start adding chronic conditions, we lose some of that initial significance of the female survival advantage. However, this completely disappears once you account for health behaviors for obesity and smoking, and not much of a difference is made once you added poor self-rated health. I also looked at a series of stratified models by gender just to understand what are some of the predictors that that predict mortality for each gender. For females, those who were much, much older, the 75 plus age groups, were more likely to die in a 4-year period. Those who self-reported hypertension, diabetes, and cancer were more likely to die. And former and current smokers were more likely to die. In males, those pretty much almost everyone in the various age groups were more likely to die in the 4-year period. Those with at least some college education, however, were less likely to die over the 4-year period. Men who self-reported diabetes, heart disease, stroke, and lung disease were more likely to die. Obese men were less likely to die. And the same patterns that we found with women, former and current smokers, were also more likely to die. I also plotted a series of receiver operating characteristic curves, or ROC curves, as people most commonly know them by. So with the first model of just using age in the model, you get an AUC of 0.739, which is a fair result. And as you add subsequent variables into the various models, prediction improves a little bit, and it does improve significantly when I did the various ROC comparison tests. And you see that the increases in prediction are about the same between males and females, and it stays at about 0.75, 0.78. So to kind of conclude, or to kind of summarize what we found, we did find that there is this female survival advantage. So being female was associated with a lower mortality risk. However, this female mortality advantage erodes when health behaviors are accounted for, particularly smoking. And among both genders, diabetes and smoking are 2 important predictors of mortality for both genders. So when we're kind of trying to contextualize what these findings mean, there are some limitations that we have to point out. There is an issue of censoring. We have to think about the selection of the sample that makes it to age 60. So those who may be truly disadvantaged may not have made it to the initial PREHCO sample. They could have died off before that period started. In addition, I'm using a 4-year window to assess mortality, which may not accurately capture the experiences of those dying in the elderly population. But then again, this is very common in our studies of mortality among older age groups, so these limitations are fair. And I just want to quickly acknowledge my funding from the NIA and the USC Davis School of Gerontology that made it possible for this research to be done and for me to be here. Thank you. questions.
Thank you so much. So open it up to the floor.
Sorry.
I was wondering about the smoking variable. Is that the thing that's really causing conversion?
Yeah, because I also did individual. I entered the variables separately individually, and smoking is what caused the complete reduction and loss of significance.
And so women are smoking more than men, I thought you had said the reverse.
Yes, men were more likely to smoke in the sample, but however, when you enter these variables into the model, smoking accounts for the gender difference.
So I guess I don't understand why that would be.
Me neither. That's
Men
the
are
future
more likely to
direction that.
smoke, but smoking in the model completely attenuates the effect. And you said the directions of the smoking effect were that smokers are more likely to die. So
Right.
that's what you would expect.
So
I
maybe
can't
smoking
understand
really
that
matters for women.
result.
Who knows?
That's sort of one mystery that I would want to dig into. And the other thing, which I think is fascinating, and this would be highly unusual, that controlling for that smoking, there's essentially no difference in mortality by gender. That's sort of amazing.
Right. I know, definitely for future directions, I do really want to dig into that more deeply because I found that was one of my most fascinating findings in doing this analysis.
Well, are there separate equations estimated for male and female so that the effects of these covariates can differ across gender?
Yes.
So it's fully interacted. Okay, so that's not what's going on then. No, it's puzzling.
Did they collect Social Security numbers to be able to link to
No,
deaths?
no. Unfortunately, PREHCO just stopped after those 2 waves, and it kind of just, the people who were doing the data kind of let it go after that. So there's no linkages, there's no biomarkers, there's.
Yeah, it would be interesting to see the correlates of attrition so you can understand what kind of differential.
I know that would be
there
very
might
interesting.
be,
Unfortunately,
because
there's
your
no.
attrition was almost as big as the deaths, right?
Yeah. Unfortunately, there's no HRS for Puerto Rico, so.
And have you, do you know whether in other, like the NHIS linked mortality data, is there a substantial number of people born in Puerto Rico in these data?
Not that I've been able to find.
Anyone else looked at that?
NHIS, because you know how the. Yeah.
Wait, but you know.
The NHIS.
Not to island Puerto Rico.
No, I'm talking about the.
Puerto Ricans on the mainland?
Yeah.
You do.
Oh, yeah. We do.
Like, people have pulled out the Mexican subsamples, there's big enough
She has
Mexican
pulled out
subsamples to
Puerto
look at
Rico.
this.
She's pulled
Oh,
out-
no, I thought he was referring to the island.
Yeah. No, I'm those who were born in Puerto Rico but have moved to the US.
Oh, okay, I
Able to
see what you're saying.
compare those and understand more about this selection. Would be fascinating to incorporate in here. So are there substantial samples then?
I would, not by individual year, but if I pool them, I can get a large enough sample size.
Yeah, I think that would be really fascinating. Other questions?
Thank you, despite me
Well,
being
thank
sick. Thanks for listening.
Okay, good morning, everyone. I'm really excited to be here today, especially to present this talk to this audience. So today I'm going to be talking